Thank you, Marie Claire. Are you hearing me and seeing me okay?
We can hear you very well and we can see you. Thank you.
All right, so let's move ahead. I'd like to thank you very much, Marie Claire and Celine and the rest of the foundation for the opportunity to review with all of you today current concepts, sort of an introductory overview to this relatively new concept in the medical field on mast cell activation disease. Our objectives today will be to review basic concepts regarding the mast cell activation disorders, or MCAD, spending most of our time looking at the new kid on the mast cell activation block, so to speak, mast cell activation syndrome. Spent a good bit of time reviewing the clinical presentation of MCAS and also a fair bit of time looking at hypotheses regarding the intersections between MCAS and POTS. At the end, briefly talk about a general approach to diagnosis and treatment of MCAS. I have no conflicts of interest to declare, and please note that there are no medications yet officially approved by any regulatory body anywhere on the planet for MCAS. So all of the any drugs mentioned herein, it's just expert opinion on their use in the setting of MCAS. We'll spend a little bit of time up front talking about what we've long known about the mast cell activation disorders, principally allergic diseases and rare mastocytosis, but spend most of our time on mast cell activation syndrome, briefly touch on research issues at the end. I'd like to start by giving you a direct illustration of one of the most challenging and frustrating aspects of dealing with this disease, the incredible heterogeneity and diversity with which this disease presents in different affected patients. And we're going to start with two cases that, at least superficially, appear sort of diametrically opposed to one another. My very first patient, in whom I came to recognize that MCAS is what was at the root of what was going on with her, she had presented with a dominant issue that had been actually misdiagnosed as the relatively uncommon malignancy of the red blood cells called polycythemia vera. And then I'll move on quickly to another case that I saw shortly thereafter, who had exactly the opposite red blood cell problem of pure red cell aplasia. And yet both cases turned out to just be different variants of the same root problem of MCAS. But then, to further illustrate just how heterogeneous this is, I'll briefly present a third case headed off in an entirely different direction, a lady who had something called burning mouth syndrome. So let's dive into it. The lady with P. vera, or what came to be diagnosed as P. vera, had been healthy for the first part of her life until noticing a migratory rash, and over many years began developing other constitutional and neurologic issues. She was a pretty stoic, independent, small businesswoman, didn't go to the doctor very often, but when she did, evaluations for these various symptoms were unrevealing. Finally, the fatigue got to a point she went to her internist in her early 50s, and in 2005, and the internist, of course, checked a routine set of blood counts, expecting he would find anemia to explain her fatigue. And to his surprise, he found exactly the opposite. She had a mildly elevated hemoglobin. So she was referred to a local hematologist, who unfortunately did testing, which at the time was really insufficient for establishing a definitive diagnosis of PV. He made the diagnostic call a bit prematurely and began standard therapy for PV, which is called therapeutic phlebotomy, where essentially the excess blood in the patient is just drained out periodically. Now, you'd like to think that if you give the right treatment for the right diagnosis, the patient gets better. But she actually just kept getting worse in a myriad different fashions, as you can see listed here. Ultimately, became so disabled with various symptoms, she had to close her business. Kept begging to be referred for a second opinion, but the hematologist was quite confident he had the right diagnosis. And so finally, she self-referred and landed in my clinic at a nearby academic medical center. And on the initial evaluation, it took about 60 seconds of history to realize she couldn't have P. vera because, well, I'm a hematologist. I know that disease, and she wasn't behaving anything like PV behaves. Examination didn't show a whole lot. I actually was able to do the testing that had newly come along about that time, mutational testing called JAK2 testing to prove she didn't have PV. So then the question became, well, what else do you have that can drive not only excessive red blood cell growth, but also all the other symptoms you're having? There actually were features to her presentation at the beginning that had me suspecting she had the rare mast cell disorder, a cancer of the mast cells called mastocytosis. So I did the testing I had been taught to do for that rare disease I had seen perhaps once previously in my training and career, and all the testing was negative, including blood and urine testing and marrow and rash biopsies. But the more I kept seeing her back, the more it just kept smelling like I would expect mastocytosis to smell like. I began reading more and more about the disease, learned about other ways to assess for mast cell disorders, finally began running some other more exotic tests I had never run before, which proved to be quite technically challenging tests to run properly. I made every mistake one can make in the book, but I worked through it all, corrected it all, and finally found an elevated urinary prostaglandin D2, which is pretty specific for a mast cell disorder. And again, this is at a point where the only mast cell disease we knew of was mastocytosis, but it wasn't in the bone marrow, wasn't in the skin. And I'm an oncologist. We're trained that if you're going to diagnose a malignancy, you have to find the malignant cells. So I pondered where else to go looking, and for various reasons decided the easiest and safest place would be the GI tract. So sent her off for upper and lower endoscopy, which was all completely normal. I persuaded the gastroenterologist to take biopsies anyway, and the pathologist initially told me they were all textbook normal. But I had learned through the reading that there was special testing that had to be done to actually see whether there were any mast cells in the specimen. So I persuaded him to do that. You can see here that with the routine hematoxylin and eosin staining, this is a section of duodenum that looked completely normal, but with the special so-called CD117 staining, it was immediately apparent that many of the cells that had been thought to be lymphocytes on routine staining, in truth, were mast cells. So I called her into the office and said, I'm not quite sure what to call this other than atypical mastocytosis. And there was essentially no guidance in the literature at that point how to manage it. We were just beginning to learn at that point that a low dose of the relatively new drug imatinib, which had originally been developed for a type of leukemia, and was spectacularly successful for that type of leukemia, CML. But we were learning that low doses of imatinib were also quite helpful for the ultra rare cases of mastocytosis that behaved atypically. And so it wasn't quite clear how to dose it. I kind of made it up, and we started with the lowest available dose of 100 milligrams per day. I told her that if after a week you're not feeling any better, then double it, and we'll see in a month and take it from there. So she came back in a month and told me Indeed, the first week she tolerated it okay, but didn't notice any improvement, so she doubled it. And then she woke on the morning of the 5th day of double dosing. So she had had 4 days of double dosing. She woke the morning of the 5th day, had not even had the dosing yet that morning. But just on waking, lying there in bed, she was acutely cognizant that all of the symptoms she had been suffering for many years by that point were completely gone. So she leaped out of bed instead of taking the 2 hours to crawl out of bed that she had that it had been taking her for many years at that point. And she put her whole life back together. This slide is a little out of date. Her improvement is sustained nearly 14 years now. And she just put her whole life back together and has been doing quite well since. Now, literally the day after I saw that response, I did an initial consultation on this woman, also in her early 50s, who she had actually had already been certified by 3 other community hematologists and 2 academic hematologists having the exact opposite red blood cell problem of pure red cell aplasia, in which the bone marrow completely gives up making red blood cells. Usually this is due to infection or chemical exposure of one sort or another. In her case, no cause could be identified despite extensive evaluation. She had been tried on every known treatment for PRCA. Nothing worked. She was intensively transfusion dependent just to maintain a barely half normal level of hemoglobin. And so when I saw her, what struck me immediately was that she didn't have just the symptoms you would expect of significant anemia. She had 500 other symptoms that PRCA could not possibly explain. And thanks to my expanded understanding of what mast cell disease had potential to do in the context of all the reading I had done, in the context of the first patient, and given that she had already been evaluated for so many other issues and everything, every other reasonable diagnostic consideration had been ruled out, I began to wonder if she just had a different variant of this atypical mastocytosis. So I ran the testing and sure enough, found the evidence. I diagnosed her with the new term mast cell activation syndrome that was just coming into the literature at that point. Because she clearly did not have classic mastocytosis. And with just plain old antihistamines alone, H1 and H2 blockers, we got a nice improvement in hemoglobin in just a month. She no longer needed transfusions. Still a far cry from normal, though. I tried a number of other mast cell targeted drugs. Nothing worked. Finally broke down and gave her the very expensive imatinib, and bingo, in just 6 weeks, normalized her hemoglobin. We actually lost that response about a year later, and I had a chance then to try a drug that I had previously been precluded from trying by her insurer, and once again gained remission in just a month. Now, all the time I was evaluating those patients, I had already been working for several years on another patient who in her early 50s had fairly acutely developed this constant burning pain throughout the entire GI tract, by far the worst in the mouth. I would put her pain score at 11 out of 10 every waking minute of every day. And how in the world she did not commit suicide from the severity of this pain, I have no idea. But in any event, she underwent extensive evaluations over about a year's time to try to find the cause of all this. No cause identifiable. Finally, a rather enterprising endocrinologist wondered maybe she has an atypical presentation of a fairly rare type of cancer called a neuroendocrine cancer. So he ran the testing, a chromogranin A level in the blood that sometimes marks for this type of cancer, found she had a 100-fold elevated level and concluded she must have a neuroendocrine cancer. So off to the oncologist hematologist she goes, and landed in my lap because I was the member of my academic hematology oncology division at the time, who was essentially the dumping ground for the mystery cases. So I went into the initial evaluation. She obviously was miserable from the pain, but curiously did not look anything like you would expect a patient with the advanced cancer that you would have to produce such a high chromogranin A level would be expected to look like. But nevertheless, I had not been taught anything else that could cause such a level. So you don't want to know how much money I spent looking for her neuroendocrine cancer. Couldn't find it. I consulted many other experts in that area. They all insisted it must be a neuroendocrine cancer. And I just needed to keep repeating all of these expensive tests every few months until the cancer finally showed up on one of them. That really didn't sound sensible to me. I didn't do that. I looked in other directions. You don't want to know how much effort and expense was invested over the next few years trying to figure out what was going on in her. But around the time I started coming to understand MCAS in those first two patients, it then started me wondering whether maybe this patient too just had a different variant of the same thing. So I had the pathologist call up her old GI tract biopsies, apply the special staining for mast cells, and bingo, there it was. So I was able to give her a diagnosis, and with just plain old antihistamines and some nonsteroidal anti-inflammatories overnight, dramatic reduction in the pain. I called up our chief oral surgeon. These patients tend to gravitate to the dentists and the oral surgeons because no other doctor wants to deal with it. And even the oral surgeons and dentists hate seeing these patients because they can never figure out what's causing it. And I said, I've got an idea. Why don't you send me some of your BMS patients? And he was only too happy to do so. I ran the testing, and there it was in every single one of them. And they all quickly started responding to various mast cell targeted therapies. So the point of all this is that these were highly divergent presentations, but ultimately just different variants of the same root disease. So how is it possible for one disease, so to speak, to do this? And could other weird presentations be possible? But before we go answering those questions, let's first look at what we've long known about diseases of the mast cell. You know, they say if you don't know your history, you're doomed to repeat it. So let's look at what we have already known about the mast cell, starting with the most prevalent form of mast cell dysfunction by far, the assorted allergic diseases that are present in about 10 to 20% of the world population. It's quite clear that the incidence and prevalence of these diseases has been increasing in modern times. A number of theories as to why that might be, but nothing proven yet. We know these disorders are driven by a variety of genetic and environmental factors. But fortunately, there's relatively little mortality with these disorders, but you can't at all discount the significant quality of life effects these disorders bring for the duration of a largely normal lifespan. So these are quite significant disorders. Now, contrast that prevalence of 10 to 20% with the remarkable rarity of the malignancy of the mast cell called mastocytosis. We actually first came to see this disease before we even knew the mast cell existed. First recognized in this odd rash that you saw in those first two pictures of urticaria pigmentosa, then took another decade before the mast cell was discovered, another decade before we realized that mast cells were at the root of what was going on in UP. Took another half century before we realized that mast cells could cause internal disease beyond just skin disease. And that was about the time we started learning about all the different mediators that are produced and released by the mast cells. Fast forward another half century, and we started getting the first publications in the literature suggesting that You know, there's this disease, mastocytosis, that features not only um, um, the inappropriate proliferation of the mast cells, the inappropriate overgrowth of the mast cells, but also inappropriate activation of the mast cells. That is, inappropriate production and release of all these mediators the mast cell produces. Well, there if there's this disease called mastocytosis, then there probably ought to be diseases where you just have the inappropriate activation with little to none of the proliferation of the mast cells. So that was a concept that was first published back in the 80s. Also in that decade began developing various classification systems for identifying various subtypes of mastocytosis. In the 90s, we learned about this one particular mutation in codon 816 of the transmembrane tyrosine kinase enzyme called KIT that studs the surface of the mast cell and is known at this point as the dominant mast cell regulatory element. And we identified that mutation as present in KIT in almost all mastocytosis patients. We also began learning about some other ways of identifying malignant mast cells. And in 2001 is when the World Health Organization came out with its own classification system for the different forms of mastocytosis that we've been using ever since. And coincidentally, that year was the same year that imatinib was introduced for that form of leukemia that it was designed for. And it did not take long before some smart folks realized that that drug would also work quite well for the very rare forms of mastocytosis that did not feature the codon 816 mutation in KIT. Over the last 20 years, we've slowly come to understand that the overgrowth of the mast cells in mastocytosis, the so-called neoplasia, causes symptoms and problems only in quite rare and ultra aggressive forms of mastocytosis, so-called advanced or aggressive systemic mastocytosis or mast cell leukemia. And instead, it's the inappropriate activation of these malignant mast cells that's actually causing all the symptoms in the vast majority of mastocytosis patients. So that's what we've long understood about that rare disease. And this is what the total spectrum of mast cell disease had long looked like up until that point. So you had this mountain of disease. This is not drawn to scale, but you get the concept that the allergic disorders constitute the large majority of this mountain of mast cell disease. And it's just the tiniest tip of the mountain that features mastocytosis in its various forms, ranging from cutaneous mastocytosis, most commonly seen in children, and about tenfold more common than the adult form in middle age to older age of systemic mastocytosis. Now, the entire mountain of mast cell disease features inappropriate mast cell activation, but it's only the disorders at the tip of the mountain that additionally feature the grossly excessive proliferation of the mast cells that we call mastocytosis in various forms. So now let's pivot and look at the much briefer history of what is now called mast cell activation disease, or MCAD. So again, the first hypotheses that a disease of inappropriate mast cell activation with little to none of the proliferation. Those hypotheses were first published beginning in the 80s. Took another quarter century before we actually had the first published case reports of what is now called mast cell activation syndrome. And that same year, we actually had the first study come out showing that most people who have MCAS actually have assorted mutations in KIT, but not in codon 816. Instead, it was a variety, a whole menagerie of mutations in other areas in the KIT gene and the KIT protein that could be found in almost every MCAS patient. And over time, we began finding in other studies that you could find a wide range of mutations in other regulatory genes within the mast cells in almost everybody with mastocytosis, and we began finding the same things in MCAS patients too. In 2010, we had a study that confirmed that most MCAS patients have this plethora of KIT mutations, just generally not the codon 816 mutation. And that study actually demonstrated that few, if any, healthy people have these mutations, strongly implicating that it was these mutations that were driving the mast cells to misbehave, but different mutations drive the mast cells to misbehave in different ways. So that same year, 2010, is when we had in the literature the first proposal to rename this whole area of disease from mast cell disease to mast cell activation disease, principally just to remind ourselves in the medical profession that first and foremost, what is going on in all of these patients to drive their symptoms is the inappropriate activation. And that paper included the first proposal for specific diagnostic criteria for mast cell activation syndrome as apart from mastocytosis. But there were a number of problems with that proposal. So within a few months, an alternative proposal came out, and full disclosure, I was the last author on that study. And a few months after that, the original group came out with a revision of its original diagnostic criteria, but there remained quite a number of problems with that proposal. That proposal has since been updated and has now been retermed by some as the Consensus 1 proposal for diagnostic criteria for MCAS. And the alternative group, so to speak, has over time revised its criteria into what is now called the Consensus 2 proposal for diagnostic criteria for MCAS. The WHO last revised its diagnostic criteria for mastocytosis in 2016. They recognized at the time these controversies regarding the diagnostic criteria for MCAS, and they wisely stayed out of it. So this is the new understanding of the landscape, so to speak, of mast cell activation disease. What had previously been recognized to be this mountain of mast cell disease is now seen to be just itself the mere tip of the proverbial iceberg of mast cell disease, where what you can see above this waterline of fairly easy clinical recognizability is the whole realm of mast cell disease we previously knew about, the allergic issues and mastocytosis. But submerged below this waterline of easy clinical recognizability is this huge assortment of different variants of just different patterns of inappropriate mast cell activation that we really have not yet learned, not very well yet, how to subdivide and subclassify. We'll figure all that out in time, but it probably will be quite a while yet. So the entire iceberg, we now realize, features inappropriate mast cell activation, but it's just the tip of the iceberg that additionally features the grossly inappropriate proliferation of the mast cells that defines the rare disease of mastocytosis. So with advancing research, we're beginning to understand that MCAS is quite common within, sitting under this umbrella term of mast cell activation disease. Recent estimates showing a prevalence for MCAS potentially as high as 20% of the human population. So in truth, every doctor has been saying this throughout their career. It's just they had never been taught such a disease exists, and it presents so differently from one patient to the next that it's quite difficult to understand what the patterns are that kind of connect one patient to the next to the next. A few other items about normal mast cell biology that I think are important to understand. Mast cells are derived from stem cells in the bone marrow. They only spend a brief amount of time in the bone marrow. They exit into the circulation fairly quickly. They do not spend much time in circulation, and they quickly exit into various peripheral tissues all throughout the body. They're pretty sparsely distributed in most tissues in the body. Where they're dominantly found is at the environmental interfaces. So the skin, and other aspects of the integument, the respiratory tract, the GI tract from stem to stern, the genitourinary tract. So they're at the environmental interfaces and in the walls of all vessels and neurons. And this is exactly where you would expect to find them so that they can be best positioned to serve their principal role in human biology as the frontline sentinel against assaults and insults upon the body. There is no other element of the immune system that responds to an insult upon the body faster than the mast cell. Lymphocytes take hours to activate. Neutrophils take minutes to activate. Mast cells can activate in sub-second time. These cells typically last anywhere from a few months to a few years, and then they need to be renewed. Their principal function is to manufacture and to stock up various highly potent substances that we generically call mediators, and then to release these mediators, different subsets of these mediators, in response to different types of assaults upon the body. And these mediators then come to affect other cells and tissues in the body to help the body overall resist and recover from whatever insult was suffered. Another important thing to understand is that it does take a normal number of normally structured and normally functioning KIT molecules, KIT protein molecules, studding the surface of the mast cell to achieve normal mast cell functions, including survival of the mast cell and normal activation of the mast cell. This is the obligatory cartoon, really grossly oversimplifying the molecular pathways inside the mast cell when a molecule of stem cell factor comes to bind with a pairing of KIT molecules studding the surface of the mast cell. And once that binding happens, you get immediate alteration in the three-dimensional conformation of the intracellular domain of KIT. And it's that conformational change that leads to immediate activation of a wide range of downstream molecular pathways that ultimately results in all the functions of KIT activation, including proper survival of the mast cell and production and release of the various mediators. Now, every health professional is taught in their 1 minute of training about mast cell biology and disease that they get out of their 4, 7, 10 years of medical education. They're taught about one route by which mast cells get activated, and that is when some allergen or other provocative antigen, like from some infectious microorganism, for example, when some allergen comes to bind with adjacent copies of IgE type antibodies, which have been pre-bound to IgE receptors on the surface of the mast cell. And once that binding happens, you get instant propagation of molecular messaging inside the mast cell that results in this explosive release of mediators from the mast cell. So that's the classic IgE mediated pathway for activation of the mast cells that every doctor knows about. But it turns out there's a large assortment of other pathways for activating mast cells too, various physical forces, a wide range of receptors for other chemicals and signaling molecules and hormones in the body, even various drugs. There also are other specialized receptors for recognizing the presence of various microorganisms in the vicinity of the mast cell. So many ways that the mast cells can be normally triggered. So this is going to illustrate to you, this is a video courtesy of mast cell expert Dr. Theo Theoharides at Tufts University and Nova Southeastern University, demonstrating just how vigorously the mast cells activate. This is what happens. I hope this will show up on your screen too. This will show what happens when a molecule of the neuropeptide substance P comes to dock with a substance P receptor on the surface of the mast cell. And after these introductory comments go by, you see how quickly you get this explosive outpocketing from the mast cell, all this so-called degranulation that just happens quite explosively. It's really a remarkable phenomenon. So the mast cell is known to be able to produce and release actually more than 1,000 mediators. And in case you're getting bored listening to me at this point, I'm going to put up at the bottom of the screen for the remainder of the talk a little ticker to start enumerating for you all of the different mediators the mast cell produces. You see in the tiny font here that you can barely read what appears to be a lot of mediators, but in truth, this is itself is just a tiny subset of the vast range of mediators that the mast cell produces. So we'll move on here. These are the diagnostic criteria for systemic mastocytosis. I'm not going to go into the details here. They're not particularly relevant to this talk. Suffice to say that these criteria, they do a fairly good job in very specifically identifying cases of mastocytosis, but they do a pretty poor job in helping us understand what's going on in the vastly greater numbers of patients who have symptoms that are suggestive of mastocytosis. And yet, when you do the bone marrow biopsies and the skin biopsies, you cannot find the overproliferation of the mast cell. These patients see many doctors. They get labeled with many different diagnostic labels, reflecting the specialty of the doctors they're seeing. But the fundamental problem here is, what do you do when it behaves like a mast cell, like mastocytosis can behave, but it's not an allergic disease or mastocytosis? What do you do when it looks like a duck, quacks like a duck, acts like a duck, but it's not a duck? Well, in the realm of mast cell disease, this is where you need to start considering the newly recognized diagnostic entity of mast cell activation syndrome. Just to be clear on this point, this is not a new disease. It's a newly recognized disease. So these were the original consensus one diagnostic criteria. I don't have time to go into the details here. Suffice to say, you can see from all the red here that there were a lot of problems with these diagnostic criteria. The consensus 2 proposal is structured similarly to how the diagnostic criteria for mastocytosis are structured. So you have to meet the major criterion of a constellation of symptoms attributable to abnormally chronically increased mast cell activation. And then you have to pair that up with one or more of the minor criteria. And most commonly, it is direct laboratory evidence of elevated levels of these various mast cell mediators that constitutes the additional bit of evidence to allow a confident declaration of the diagnosis. We again, we believe this is a very prevalent disease, and it's intriguing that we are seeing in the research literature in many other inflammatory diseases of unknown origin, we're seeing increasing evidence of critical mast cell involvement in the development of those diseases. And that obviously now raises the question of whether some proportion of the population of patients who have each of these various inflammatory syndromes, maybe what's actually going on in those patients is one variant or another of MCAS. But that is just a hypothesis. There is an enormous amount of research to be done to prove or disprove that in each of these areas, and that will take decades, if not centuries, to accomplish. We know this disease is mutational in origin, not inborn mutations, but well, that's rarely seen, but far more commonly, these are acquired mutations, just as is seen in any form of cancer, including mastocytosis. But these acquired mutations don't really drive so much the inappropriate proliferation of the mast cells, that rather these mutations drive inappropriate activation of the mast cells. Just trying to briefly illustrate here just a portion of the vast range of mutations that have been identified scattered all throughout KIT in different MCAS patients. Actually, most MCAS patients turn out to have multiple different mutations in KIT, let alone in their other mast cell regulatory genes. So to return to the original question, how is it possible for one disease, so to speak, to drive so many different variant presentations at the superficial clinical level? Well, you answer the question by doing the math. Mast cells produce and release not just scores, but actually hundreds of different mediators, and any one mutation in the dominant mast cell regulatory element of KIT can lead to the abnormal release of multiple different mediators, creating some potential for multi-system illness and significant heterogeneity or diversity in the presentation of the disease from one patient to the next. But wait, it's more complicated than that, because it's not just one mutation in KIT that is seen in the typical mast cell patient. We know from the research that most of these patients have multiple mutations in KIT, but it's not the same pattern in every patient. It's different assortments of mutations in KIT in different patients, leading to greater potential for multi-system illness and diversity. But wait, it's more complicated than that, because it's not just KIT that gets mutated. We know from the research it's multiple other genes that get mutated as well in these dysfunctional mast cells. And it gets even more complicated than that, because each mediator that's getting inappropriately released from these mutated and dysfunctional mast cells has not just one effect in the body, but actually, excuse me, each mediator has its own unique and often quite large array of effects: direct effects on other cells and tissues in the body, indirect effects, local effects in the tissue surrounding the mast cell that has released the mediators, as well as very distant effects that can be accomplished by a whole variety of mechanisms. There can be acute effects, there can be delayed effects, there can be chronic effects. This is how one disease, so to speak, drives such a vast range of clinical presentations. So is it even possible to come up with sort of a general description of what these patients look like? Well, it is, but it necessarily is a pretty nebulous description. I've come to describe this disease as a chronic multi-system illness, or polymorbidity of general themes of inflammation. This is the universal constant found in all mast cell patients, multi-system inflammation, plus minus allergic type phenomena. And I say plus minus because there are plenty of mast cell patients who do not have a speck of allergy to them. And then at the opposite end of that spectrum, there are the unfortunate few patients who are suffering 24/7 anaphylaxis. And then everybody else with MCAS is somewhere in between those polar opposite ends of the allergy spectrum. And then there's one more plus minus general theme to this disease that's the hardest of all to recognize because it emerges the slowest by far, and that is the abnormalities in growth and development that can happen in virtually any tissue in the body. So the disease usually starts manifesting symptoms no later than adolescence, quite often in childhood, occasionally even infancy. But because no doctors are yet trained that such a disease exists, these patients typically go unrecognized for decades, if not even their entire life. Before it finally gets recognized. It's almost always a multi-system disease. The symptoms are almost always at least inflammatory. It's always waxing and waning its behavior. So it's a perplexingly inconstant course. And on the outside, these patients often look fine. It's just that internally they feel terrible from various inflammatory and allergic issues. Over time, this waxing and waning course can sometimes significantly escalate in the baseline level of misbehavior of the patient's dysfunctional mast cells. But when these escalations emerge, they typically come about shortly following, anywhere from a few days to at most a few months, shortly following a major physical or psychological or emotional stressor. So this is the overall natural lifetime course of the disease. Tryptase, the blood level of tryptase is a good marker for the rare mast cell disease of mastocytosis because tryptase marks for how many mast cells you have in the body. But the overproliferation of the mast cells is not really the issue in MCAS. So really, you don't find too many MCAS patients who have an elevated tryptase. And instead, and in fact, we've been learning that in the small minority of mast cell patients who have just a modestly elevated tryptase, usually that's not even coming from mast cell activation, and instead that's a genetic accident due to the patient having inherited extra copies of the tryptase gene, a condition we now call hereditary alpha tryptasemia. But in the great majority of MCAS patients, so tryptase is not going to be so helpful, and instead we have to look for elevated levels of other mediators that are relatively specific to the mast cell, but this is challenging testing for a whole variety of biological and logistical and technical reasons. It's not that it can't be done, it's just that it's challenging, and you have to be sure all of the personnel involved in handling the specimens are properly trained in how to do this correctly. Understandably, with their having so many different symptoms, these patients come to see boatloads of doctors. They acquire truckloads of diagnoses. They quite often come to be labeled as psychosomatic because all of the routine testing cannot find anything awry that explains all their symptoms. And put yourself in their shoes. You have so many symptoms, nobody can find an actual explanation for it. You might even get tried on various treatments empirically that don't seem to make any difference. So they stop reporting their symptoms. They just shut up. And that's why doctors who come to see these patients and come to recognize maybe what's going on here is MCAS, they have to work extra hard to do an especially thorough review of systems and history taking to extract from these patients the details of their symptoms that they learned long ago. It just wasn't worth telling doctors about anymore, because if they told a doctor about the same problem all over again, They would just get the same testing run again that was previously negative, and it would be a big waste. And there would be another doctor who would just be accusing them of psychosomatism. So a thorough review of systems is critically important. System by system, what does this look like? The constitutional issues are all over the map. As you see here, these are the patients who have odd and prolific sensitivities. And look at the themes here as we go system by system. It's inflammation, 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 inflammation. System after system after system after system. And in the interest of time, I'm going to go through this pretty quickly. Even the central and peripheral nervous systems can easily be involved, the hematologic systems, the clotting systems, the immune systems, the endocrinologic and metabolic systems, growth and development, as we said, can be affected. I apologize, I'm having to go so fast through the slides, but again, the slides will be made available later. So let's talk briefly about the intersection or a potential intersection between MCAS and POTS. There's no question that POTS is seen in quite a number of MCAS patients. So, the question arises, in some portion of the POTS population, is it possible that that disease, POTS, might be rooted in certain patterns of chronic abnormal mast cell mediator expression? And we've had tantalizing hints in the literature for more than a quarter century now that there might be some sort of connection here. And a few small studies have even looked specifically at potential associations between MCAS and POTS. And it does seem there's an association, but you have to be very careful here in not inferring from an association that there necessarily is a causative linkage. So it's going to require a lot more and much more difficult research to prove or disprove that certain variants of MCAS cause certain forms of POTS. But if we muse for a bit, how might MCAS drive POTS? Is it even possible from what we know about from what we know about mast cells? Well, first of all, consider the anatomy of mast cell disease. Where are the mast cells in the body? Well, they are present not only in all the environmental interfaces, but also in the walls of all vessels and nerves. And is it possible for, do mast cells actually produce mediators which can drive elevation in the heart rate, tachycardia, and a dilation of the blood vessels that can lower blood pressure? Absolutely. In fact, again, mast cells express more than 1,000 mediators, and the potential for direct and indirect, even circular signaling between the mast cells and other cells in their vicinity and even remotely located is just a vast potential. And we also have to keep in mind here the possibility it may not be the mast cells themselves that are directly expressing the key factor that is driving the abnormal heart rate and the blood pressure falls. And it might be sufficient just for the dysfunctional mast cells to be over or under expressing some key intermediary driver of the ultimate mediator that directly drives the inappropriate behavior of the heart and the blood vessels. So which mediators might be principal drivers of POTS? There's a vast array. If you actually look into the details of what all these different mediators do, and there are many others too, you begin to realize that, yep, they really do have potential for driving POTS of one form or another in one patient or another. But that doesn't mean that there necessarily aren't other ways to drive POTS. Some people have raised the possibility maybe there are autoantibodies of various sorts that are developing against relevant cardiovascular targets to drive POTS. MCAS itself might be at the root of that, because MCAS actually can drive aberrations in the immune system, including production of antibodies that the immune system has no legitimate business producing. Um, so are there arguments against autoimmune POTS? And I think there are, because what strikes me as the oddest thing here is that the flares of POTS come so quickly, and yet antibody titers fluctuate fairly slowly. They can fluctuate dramatically in terms of levels, but those fluctuations do not or tend not to occur anywhere close to the speed at which you see a symptomatic flare of POTS emerge. So it's kind of hard to understand how relatively stable antibody levels might be the proximate driver of a flare of POTS. Of course, it could be more complex. It could be that the autoantibodies create a state of potential for POTS, and then additional mast cell mediators flare up at various points and sort of push the cart over the edge to get a symptomatic flare of POTS. But that seems to be a more complicated explanation, and Occam's razor, of course, would favor a simpler solution, that it's just flarings of MCAS, just releases of different key mediators from the mast cell that are probably driving these flares of POTS symptoms. So if mast cell-based somatic mutations, acquired mutations, that seem to underlie most cases of MCAS are central to POTS, what are the chances that whole genome sequencing will find them? Pretty minimal. Most current whole genome sequencing technologies will identify a mutation only if it's present in 20% or more of the cells that are sequenced in that sample. But mast cells comprise at most only about 0.02% of all the circulating blood cells. So instead, if you're going to find these mutations, you've got to first extract the mast cells from the rest of the white blood cells, and there are a couple of different methods for doing this, and then you apply the sequencing to the isolated mast cell population, and that's when you'll finally start finding all these mutations. And this is exactly the approach that the researchers, principally at the University of Bonn, over the last 15 years have taken to find all of these acquired mutations in the mast cells in MCAS patients. So no clinical laboratory anywhere on the planet yet offers this mast cell focused sequencing. I'm expecting it'll be at least 10 to 20 years before that testing migrates from the research labs to the clinical labs. Ultimately, when the testing does become available, I think it'll be commonly ordered, and we'll start understanding the patterns in how the correlations between given mutations and given symptoms, and even more importantly, identify the correlations between given mutations and which drugs tend to best help the individual patient. So with the disease presenting in so variable a fashion, how do you best diagnose it? Well, you got to fall back on the physician's best friend, a complete history and physical, and you have to put your faith back in Occam's razor. These patients who have a problem list of 50 different problems, no, it's not that they have all these problems developing independently of one another. Rather, it's just one diagnosis that really is biologically capable of causing all the trouble. It's just a diagnosis we didn't previously know exists. You do have to take care of considering the possibility there might still be other diseases there. It's not impossible. So there's a variety of other things that have to be considered. Very briefly, this is the diagnostic workup at present. First, you have to suspect the disease. If you don't even suspect it, you'll never diagnose it. Then you do initial testing, perhaps a tryptase level. If it's highly positive, then you need to go looking for mastocytosis. But otherwise, you drop into this bottom box where you got to go doing all this other more challenging mast cell mediator testing. Prognosis at present seems to be a fairly normal lifespan for most MCAS patients, but it's a chronically symptomatic life. And this is why it's so important to get it diagnosed and treated as early as possible so you can have a better quality of life for the remainder of a normal lifespan. Treatment, don't have time to go into details. Suffice to say that we first try to identify and avoid triggers, and we try to inhibit the production of mast cell mediators. Then we try to inhibit the inappropriate release of mast cell mediators. If the mast cell mediators do get inappropriately released, we try to block their actions on the other tissues. This is not a cancer. We really don't need to be using cytotoxic chemotherapy. In theory, allogeneic stem cell transplantation can be curative, but there are all sorts of reasons this would be extremely challenging in the relatively few MCAS patients that it would be reasonable to consider this extreme intervention. And of course, if the mediators are causing downstream, if the released mediators are causing downstream problems, you have to deal with all of those issues, and be careful not to assume that a new issue emerging in an MCAS patient is necessarily due to the MCAS. There are a variety of complementary and natural treatments, and even non-pharmacologic therapies. Various limbic system retraining programs can be helpful. These pictures off to the side illustrate just how closely the mast cells abut the neurons in various places in the body. Just a small listing of other syndromes, other idiopathic inflammatory syndromes where my experience has given me cause to suspect that MCAS might be at the root of some proportion of the population suffering each of these diseases. And the research obviously can head in a million different directions here, but fundamentally we need to improve the diagnostic techniques. We need to better understand what's causing all these mutations, and we need to better identify which treatments will best help which patients. And of course, we need to better educate everybody involved in this. So I'll bring it to a close at that point and be happy to participate in the panel for taking questions. And later on, if you have any other questions for me, there's my email address. You're welcome to email me. Thank you for your time.